Newborn assessments should be performed with the parents present so that you can enable them to understand their baby's general health and well-being, and also to identify signs or symptoms of health problems and to recognise when to seek further medical help. It's important to provide a comfortable, culturally appropriate environment that promotes interaction and supports privacy. This is a guide only, as the process needs to be individualised to the specific needs of the woman and her baby. The midwife undertaking newborn assessment must be accredited in this procedure. Maternal and newborn history should be reviewed prior to this examination to ensure that the baby meets the midwife discharge criteria and therefore can be safely discharged by the midwife. It's also important to have all the correct equipment necessary to perform the examination and that it's been cleaned thoroughly, adhering to hospital infection control policy. Ideally, newborn examination should be carried out head to toe, only undressing the baby as required to maintain thermoregulation. However, the examination is opportunistic and dependent on the baby's behaviour and responses.
What we're going to do is we're going to start at the top and we're literally going to work our way down.
Yep. Starting with the scalp, head and face, look for any bruising or swelling that may be evident from birth or an underlying abnormality. Then assess the baby's head for asymmetry or abnormal shape alongside feeling the sutures and fontanelles for obvious abnormalities. The face should also be looked at overall, as it can be an indication of certain syndromes. Individual components must be assessed during the examination. The clinician must feel under the chin and around the neck to assess asymmetry and to rule out extra skin folds, dimples, webbing or swelling. Full range of movement should also be noted, as if it's not present, it may indicate congenital abnormality. Clavicles should be inspected for fractures, particularly if there's a history of shoulder dystocia or a suspicion of Erb's palsy.
Looking at her head looks fantastic. It's actually really well in terms of the shape of it. You'll notice that she's actually got a little dimple, sort of like feels like a bit of dimple. That's a fontanelle, and she's got one at the back there.
Yep.
And they're actually feel very, very normal in terms of where we expect them to be at this stage, given that she's 2 days after birth.
Moving on to the skin, we're on the lookout for aplasia cutis, birthmarks, cuts or bruises, pigmentation, and assessing perfusion.
Is that a birthmark?
That there? Yes, it possibly is, actually. And do you have a birthmark yourself?
I don't know.
And her dad? Maybe it's a familial thing?
Yeah.
Nothing to be worried about. Those sort of different pigmentation like that is just very, very normal.
It's important to give parents education and information throughout the examination process, especially if there are any abnormal findings. Exposing baby's chest, abdomen and groin for inspection is important, as it allows the examiner to observe the shape of the chest, nipple position and number, heart position, heart sounds, respiratory system, shape and or distension of the abdomen, organomegaly, tenderness, peripheral palpable pulses, and condition of the cord and surrounding skin.
So much the same as again, we're just sort of moving down her chest here, and as you can see, she has got 2 nipples, because that's great. And sometimes what you find with little girls, it can actually be quite swollen. Yeah. That's very, very normal. That's just as a result of the hormones in pregnancy.
Okay. Yeah.
So essentially that will subside. Her tummy looks like it's irregular in terms of the shape. There doesn't seem to be sort of one more side larger than the other.
Yeah.
And in terms of her cord, that's really, really clean. And that's obviously healing really, really well.
Check the overall appearance of the female genitalia and discuss with the parents the possibility of a withdrawal bleed due to the maternal hormones and not to excessively wash off the vernix.
Now, little girls, obviously, they have what we would say is their normal external genital area. It can be quite swollen, Jane.
Yeah.
That's very, very normal. We would expect that, and the swelling will go down.
With male genitalia, check that both testes are present and descended, the shape and size of the penis, the position of the meatus, and the stream of urine. The limbs must be examined to make sure that there are no abnormalities, as well as checking the movement of the hips, the spine, the anus, and bowel movements.
To make it so it's straight.
Yeah,
so
just to make sure to make sure that they're actually not dislocating or that they're not clicky. Because if there's any concerns with that, then finding out earlier is much, much better for Olivia and also for ongoing treatment as well. What colour are her poos now? They probably were quite
A light yellow.
You like yellow? Yeah, that's very, very normal given that you're breastfeeding. And the fact that she's weaning is good too, because we know that her urinary system is working as we would expect it to be. We're certainly counting her toes and her fingers, so we've got obviously all the amount of toes and fingers that we would normally have. Looking also, when I was looking at her legs, I'm looking at the shape of her legs and the fact that they look very, very similar in terms of not, there's not creases in one spot that's different to the others. And so what I'm doing here, James, I'm just actually running my finger down her spine and I'm actually just checking to see if there's any lumps or anything that feels irregular.
Now the baby's reflexes can be checked to assist the clinician in assessing the workings of the central nervous system. It's important to identify whether or not the reflexes are symmetrical. The reflexes to test are the startle reflex, the rooting reflex, the sucking reflex and the grasping reflex with hands and feet.
You can see when I hold her up like this, she'll start to run with her legs almost trying to stepping. I'm just literally going to move her relatively quickly down and would expect her to respond to that. Okay, see how she put her arms out? Very, very normal. Now those reflex testings that we've just done help us to see that her brain is working as we would want it to be for a newborn. Okay, so she's doing that stepping quite easily there as well.
It's also important when assessing reflexes to hold the baby in the midline and in a neutral position. The clinician should be familiar with the normal anatomy of the eye in order to identify abnormalities. They should examine the position and size, surrounding features, exudate, palpable fissures, sclera, iris, cornea, and elicit a red reflex.
And what I'm actually looking for in here, I've got one there, a red reflex, to let us know that there's no problem with the way that the
Where
lens
can you see that in the
right in the middle part of the eye. It's quite a.
So right in the purple.
Yep. There's another one there as well. Good girl. When she's looking at me like that, I'm actually looking at her eyes and I'm looking at how she's focusing on me and where her eyes are in regard to the level of her ear and whether or not there's any redness in her eyes. Have you noticed any redness in her eyes?
No, not really.
No.
The nose should be checked for position and patency and the mouth for any abnormalities such as cysts or neonatal teeth. The palate should be checked and also the tongue size and the floor of the mouth.
We can see that both of her nares are what we call patent, so there doesn't seem to be any blockage there. What we often do too is we just literally want to feel her palate. It doesn't taste nearly as good, does it? I'm sure.
The ears should be checked for size, shape, position and abnormalities, inclusive of skin tags or dimples. This is a good opportunity to discuss the hearing test procedure, results and follow-up if required.
In terms of her ears, obviously we want to make sure that she's got the shape of her ears and the level of them, and there doesn't seem to be any blockage or any skin tags and that sort of thing.
Documentation is usually completed at the end of the examination, and it is important to document all findings in the appropriate place. Documentation should include the baby's case history, the discharge chart, the maternal child health green book, and computer details. Jane, you'll find a list of the signs and symptoms of illness to refer to in your mother and baby booklet. At this point, we should be discussing the importance of the follow-up with other care providers and a repeat of the newborn examination at various stages.
What will happen is in the next couple of weeks, obviously you'll be seen by the KMS team. They'll be coming and seeing you over the next 6 weeks. It's important for you to make an appointment for Olivia to be seen by your GP within 6 weeks of birth. And that's a good opportunity for you both to actually go for a checkup, but particularly Olivia. And there's a little place in your booklet here where we've got the contact phone numbers for if you need to speak to anybody about any concerns. So it's a good idea to put that on the fridge at home so that you don't have to go looking for that.
The final part of the newborn exam is to complete areas that have not been performed sequentially due to the response of the baby, if required.
Walking in